Okay, so this is big news in the realm of HIE and in particular neonatology and pediatric neurology. This is a brand spanking new, hot off the press yesterday, collaborative clinical report between the Committee on the Fetus and Newborn and the Section of Neurology in the American Academy of Pediatrics. And so this is like a 30+ page report on therapeutic hypothermia or cooling for neonatal HIE. The lead author is Dr. Santina Zanelli, and then Dr. Courtney Wusthoff, who is Dr. Zanelli is a neonatologist, Dr. Wusthoff is a neurologist, and then we have a couple other neonatologists that are listed here, but there's a whole work group that's listed. Point, though, there is not a single patient family representative on any of these work groups, despite what I'm about to talk about, which is where they're talking about including families and improving care, but also families were not included in this co-produced work group. So there's a lot of parts of this report, and one of which I think a lot of these things actually are really helpful for families because a lot of these things answer a lot of the questions that come up often in our community, especially from new families in the first 2 years. One is always what qualifies someone for cooling? Well, here's the algorithm that the AAP work groups have produced and published on. Here's some questions that are often asked by families, especially if you fall into these different pockets and cohorts. So one is the later initiation of therapeutic hypothermia outside of that 6-hour window. And so really there's not a lot of great data that shows that it is beneficial, but here's the key action statement. Initiation between 6 and 24 hours of birth may be considered after discussion with the parent or guardian of possible benefit and associated risk. Bingo, bango. The next section is about cooling on transport and what the standard should be, what is the optimal for babies with HIE on transport and initiating cooling. There's been all sorts of things about passive cooling and cooling systems and things like that. So basically the recommendation is whenever possible, use the controlled cooling, which is preferred to passive cooling, so you're not overcooling a baby and causing additional problems. Next is a real hot topic because this Neonatal Research Network trial results published last year about cooling for late preterm infants between 33 weeks and 35 weeks. There was evidence that showed that the cooling group had higher mortality rates. And so the recommendation is that it is not recommended for infants less than 35 weeks gestational age. Of course, it's really tough sometimes to tell, do they fall in by a day or two? And once again, what I love about this is saying that it should be considered to discuss with families. There have also been a lot of physicians that have been worried to say that is too much onus on the families. And I think this is the healthy tension where a lot of our families wish that they had been asked and given that information, even to opt out. But if they had been educated more on the risks and potential benefits. Next section is therapeutic hypothermia for neonates with mild HIE. Many of you know that we are involved in the Cool Prime study, which is looking at comparative effectiveness of normothermia, which is just keeping at that maintained normal temperature, and then initiating therapeutic hypothermia for mild HIE. At this point, the recommendation is not to cool mild outside of a research study. So that's a little bit different in that they're not saying talk to parents about it. We know that some sites do that. There's a lot of sites that have what's called a therapeutic creep outside of what the recommendations are. So there's a lot of contention and lots of big feelings and big thoughts behind this. In particular, I think on all sides, on the family side, on the physician side, lots of contention always to talk through with that. The next section is really talking about the need for additional clinical trials with different, add-on drugs or therapeutic advancement, which we share a lot of what the updates are. There's currently so many things in this clinical pipeline for HIE in particular. And so moving those things forward, there's obviously a huge need. Cooling has done amazing things to save brains and save babies, but it is not as effective as I think everyone would love, and we have no shortage of need. And trials for HIE in low and middle income countries where cooling is really not feasible because it is such a high resource need therapy. So looking at things that would be more feasible in those settings. And then the next one is neurodevelopmental follow-up. And this is one that we also talk about quite a bit of the need to develop guidelines because there is very little evidence of who needs to be in neurodevelopmental follow-up. We feel strongly that any baby with a diagnosis, mild, moderate, severe of HIE, should be in developmental surveillance of some sort. And this is talking about the timing and intensity of follow-up is based on severity, results of the brain MRI, presence or absence of feeding difficulties, and need for medication. I don't know if those are great qualifiers. I don't know if I love that. It's because there's not enough evidence. We don't have any guidelines to base it off of. So Hope for HIE has developed a response, an official position statement about this very large clinical report and our key points of agreement and things that we think really need to move forward and points that we disagree and would like to move forward. So starting off strong with number 1, family consultation on borderline and late initiated cooling. Love that. Love that they're thinking about including parents. They need to. It's their baby. They need to really, medical teams need to work on shared decision-making and implementing that as standard of care. Equity and access to therapeutic hypothermia and other interventions. Absolutely. We know that that's an issue and really, agree with that. Family-centered care is essential. We agree completely. And we know that better communication practices, scripting, resources, all those things, family-centered care for HIE has kind of been ignored. And there's lots to be done with developmental care opportunities during therapeutic hypothermia that parents can do and participate in. And a lot of times neonatal therapists would be the ones to facilitate those things, or nurses. And a lot of times they do not have the opportunity to get in there early with taking care of the babies and families during this time. And then acknowledging the uncertainty for mild HIE. We need more studies, better studies that include what matters most to families and the experiences and long-term outcomes. In particular, school-age outcomes for mild HIE have been downplayed for so long, and it's pretty much every day that families are saying we're really struggling when it comes to school. We're seeing later onset epilepsy. We're seeing behavior concerns. We've seen this in some of the new data from the Neonatal Seizure Registry as well. So just that we need more of, attention to and agreeing with the AAP clinical report. Areas for continued progress. We're looking at the inclusion of families in research in mild HIE, of course. And then looking at what are the standardized follow-up at key neurodevelopmental time points. Again, not just by severity, but by the diagnosis. Inclusion of patient family input in developing these guidelines, clinical reports, and published articles. Again, there was not a single patient family was included in the writing of this or co-producing it or any sort of that. We're responding through a position statement. Okay, this was a point that was interesting as well. The verbiage and language that was used about the involvement of pediatric neurology was really soft and positioned neonatologists as like the gurus of HIE. And really what we see in practice is that it's really a collaborative care model. And if you're nudging out pediatric neurologists, that's not best for families or the baby's care. And that neurology consultation and involvement is critical and essential for families facing HIE and especially the babies. And so they are a part of the longitudinal care team. Neonatologists are very much involved, obviously, in the acute care, but they need to work collaboratively with their pediatric neurology colleagues for families. It's not that neurology can be valuable, it is essential for these families. Again, long-term follow-up and support. The AAP emphasized early developmental monitoring. Follow-up rarely extends in the school years, which we just talked about. And then looking ahead. So we have this new floor, but it's not the ceiling. So we have a lot more work to do together, lots of things to move forward. And we'll just continue forward partnering. So if you have need more information, head to our blog. This is all there.